Thank you for allowing me to present earlier. Sorry for skipping the queue. I have a ICE in Holland. So today I'm going to present on dot and blot hemorrhages. So it's a very basic topic. So today's my overview for presentation is origin of dot and blot hemorrhages, common causes and how to differentiate, and when to refer. So if we see, this is a basic presentation for just who has passed out for their post-graduation. So these are how dot and blot hemorrhages looks. So these are dense, dark red, sharply outlined, and are seen in disorders that are affected the prevenular deep capillary layer. And if we see for the origin, it's microaneurysm occurs secondary to capillary wall outpouching due to parasite loss, and they appear as a small red dots in superficial retinal layers. And there's fibrin and red blood cell accumulation in microaneurysm lumen, and the rupture of that produces blot or flame hemorrhage. So if we see dot and blot hemorrhages occur as a microaneurysm rupture in the deeper layers of the retina, such as internuclear layer, outer plexiform layer, and this appears similar to the microaneurysm if they are small, and fluorescein angiography may be needed to distinguish between the two. So these are basically intraretinal hemorrhages. So if we see common diseases and differentials for that, so the location, size, and the distribution of the hemorrhages provides clues to the etiology and uncover underlying systemic disorders such as vascular disease, hematologic disorders, and dyscrasias, and infection, trauma, and hypoxia. So if we see in diabetic retinopathy, we see dot and blot and vitreous hemorrhages can also be there. Bilateral, diffuse, distributed in the posterior pole dot and blot hemorrhages, we see in that. If we see in RVOs, diffuse intraretinal hemorrhages in all quadrants, in central vein occlusion, and sectoral distribution in branch vein occlusions. So here we can see on the left side it's on superior hemi-RVO, and right side we can see CRVO. So here also one post-op case where inferior hemi-CRVO is there. And ocular ischemic syndrome, if we see in that mid-peripheral intraretinal hemorrhages can be there, retinal neovascularization can be there, and sickle cell retinopathy. If we see intraretinal Salmon patch hemorrhages, and with that black sunburst, chorioretinal ischemic scars, and CFAN neovascularization, which might lead to vitreous hemorrhage, and they are seen usually bilateral. So in juxtafoveal telangiectasia, if we see, it's a typically central dot and blot hemorrhage with the chorioretinal scar and vitreomacular traction. So if we differential according to the age group, so there can be neonatal if hemorrhages are there, then they are from birth trauma, including spontaneous vaginal delivery, vacuum extraction, and double instrument deliveries can also cause that. Infant and children, if we see child abuse, coat disease, persistent hyperplastic persistent vitreous, retinopathy of prematurity, retinal dysplasias, hypertension, myopia can cause that. In systemic, if we see hematological or cardiovascular disorders, infections, protein C and vitamin C deficiency can also cause that. And adults, if we see diabetes, hypertension, leukemia, blood dyscrasias, hypoxia, anoxia, and high altitudinal syndromes, high myopia, posterior vitreous detachment, retinal tear, and detachment can also cause that. And if we see treatment, it's basically a total systemic treatment or systemic workup we have to go for that to detect underlying cause for the hemorrhages. And management consists of observation and treating the primary cause, and intraocular management to reduce the ischemic and neovascular sequelae following the hemorrhages. So if we see, most dot and blot hemorrhages are not vision threatening and are usually found in the posterior pole sparing the fovea and can be observed. And hemorrhages seen in the retinal vein occlusions are not treated per se, but the retinal edema or the neovascularization which follows as a sequela needs to be treated. So in take-home message, if I'll say, sometimes dot and blot hemorrhages can be the tip of iceberg. We need to investigate for the ocular findings by OCT, OCTA, FFA, and for blood investigation. And if we need, we might have to refer the patient to the specialist like retina surgeon, physician, endocrinologist, rheumatologist. And timely referral can save the patient from potential complication. Because as I told here, it can be the tip of iceberg. As per se, dot and blot hemorrhages are not the disease. So we need to treat the disease basically. Thank you.
So very nice overview of these fundus findings, dot and blot hemorrhages. And you rightly pointed out, Dr. Parth, that it's the coexisting features in retina which help us make the diagnosis. The dot and blot hemorrhages only bring it to our attention that there is something wrong in retina. There are very few conditions where you will have isolated dot and blot hemorrhages and nothing else. I think one can be an impending PVD and second can be venous stasis retinopathy. It's a very incipient kind of CRVO, often related to high pressure, and sometimes sudden hypotony can also lead to isolated dot and blot. Otherwise, you rightly pointed out all the common reasons for dot and blot hemorrhages.
Yes.
Maybe Madam can add something. Or
Yeah, I think the most important thing is the systemic issues is what we have to look after. So this is just one place in the eye or in the whole body that we can see that there is a pathology, and we have to be a good investigator here to see what is going wrong.
True.
Sometimes you do see microaneurysms or hemorrhages, and there is a very strong family history of diabetes, but the patient doesn't have diabetes. I have seen it very often. So possibly there is a gene for diabetic retinopathy that is inherited without having diabetes as well. So it's not necessary that every microaneurysm has to be pathological.
Okay. Thank you.
Thank you, Dr.